Hello and welcome everyone to our first series of lectures for Peds Nursing. This week we're just going to start by laying the groundwork for our entire semester. So in this first recording we're going to explore the unique philosophy of nursing, define what your role looks like, and then examine the family and social factors that shape the health of our youngest clients. If you're interested, the content in this video relates back to Peds Nursing Today. That module is not assigned to you. However, there are some important components that I thought that we should highlight, but if you do want to look into any of it in more detail, it is available for you on ATI. All right. So, big question here. Why do we care about pediatrics? Well, I want you to take a few moments and come up with some ideas on your own. What are some of the first ideas that might pop into your head when you ask why? Now I'm going to require that you ask why a lot in this course. This is just the first of many, many whys. So just get used to it. You're going to hate it by the end, but I promise it's useful. So why does pediatric nursing matter? Go ahead and pause the video, think about it, maybe jot down a couple ideas before you move on. So you may have answered with the very cliche response of the children are our future, and you wouldn't be wrong. However, there is much more to the why behind pediatric nursing than investing in the future of humanity, although that is pretty important as well. It's important as we go through this content to remember that children are not just small adults. That is sort of the biggest reason that peds is its own specialty. So that question that I posed had a bit of a double meaning. And so while I want everyone to think about the big picture importance of childhood health, the simplest answer to why pediatric nursing is that children are just different. They're in a rapid phase of growth where their bodies are sometimes working differently than in adults. Their abilities to follow directions, heed medical advice, report symptoms, tolerate procedures or discomfort are different even across the ages of 3 and 9. So this means that there's quite a bit of important adaptation that we must do as nurses to care for kids, because if they're different between 3 and 9, imagine how different that they're going to be between the ages of 0 and 18. So the first concept we're going to discuss here is atraumatic care. This is our commitment to minimizing physical and psychological distress. So how do we do this? Well, we want to reduce stressors like pain, fear, and isolation during medical procedures and treatments. Strategies for this include things like therapeutic play. You're going to hear a lot about play in pediatrics, right? We're going to employ pain management techniques such as distraction or guided imagery, or even things like Emla cream. We're going to use non-threatening language. We're going to make environmental modifications to create a more child-friendly atmosphere. So if you've ever been up on the peds floor or when you go up there on Wednesday, I want you to pay attention to how it feels up there, because if you go from peds on North Tower 8 just to North Tower 6, you will notice that there's just a different vibe. The design of peds units, especially more so in children's hospitals, but at Carle as well, really are intentionally designed to create a warmer and more welcoming environment so that it doesn't feel quite as scary for children. So here's a few more examples that are broken into 3 pillars of reducing stress, limiting separation, and then supporting control. So these interventions are proven to improve health outcomes because the less cortisol that your body produces, which happens when you're stressed, the better it can heal and focus on what it needs to do to make itself better, okay? So proper atraumatic care is really important, but it is also significant to recognize that it takes time. This is not something that you can always do right out the gate, and so you often have to plan ahead in order to provide proper atraumatic care. We mentioned Emla cream in the last slide. How long does that take to work? Do you know? Because it's a while. It's 45 to 60 minutes that lidocaine cream has to sit on the skin. So you can't just go into the treatment room and start an IV on a kiddo. You have to anticipate that need ahead of time, or you're going to have to delay care, because more often than not, if we want to get clinical for a minute, an IV start is usually not planned, right? Usually an IV gets blown, you have an antibiotic due, you have to get it started, and so you're going to have to expect that this is going to be a multi-hour sort of thing that you're going to have to plan for before you can get those IV antibiotics going again. Another major approach in peds is family-centered care. So this recognizes the role of the family in a child's life, especially when it comes to healthcare. So this approach works to treat the emotional and the social health of the family as being integral to that child's well-being. So we really, want to rely on the expertise of the caregivers in the family and collaborate with them to help support everybody in the family unit. So this includes things like taking into consideration their cultural values, their preferences. We treat the whole family as the patient, all right? And this is something that students, I think, find the most jarring when going from adult med to pediatrics is, you walk into that room and you have to decide, am I going to address the child in the bed first? Am I going to address the parents? Oftentimes you're talking more to the parents than to the child. It's much different than in the adult world. You have to be prepared to answer a lot of questions that you might not be used to answering. So things like, is it my fault that he's as sick as he is? What did I do to cause this? What could I have done to prevent it from a child? That could be something as simple as, can my blue truck also eat some of my pudding, to something more complicated. So we have these 4 concepts that come from the Institute for Patient and Family Centered Care, and these map directly to clinical practice. So I want you to take a look at these 4 ideas and think about which concept you would be most likely to skip if you were under time pressure. Let's say, again, your antibiotic is due, your IV has blown, you need to get a new IV started, all right? When you're going through that process, which one of these would you be most likely to skip? The common answer for this is usually information sharing. So as nurses, we'll often jump into doing things without explaining them in the hopes that our patients will just trust us. And in adults, this can sometimes work. You go in to start an IV and they usually know what an IV is and you explain to them why they need it. But with a child, you have to do a little bit more than that. You have to explain it to the parent. You also then have to explain it to the child and walk them through. So skipping that information sharing stage is often the wrong approach in peds. Another point in here I want to talk about real fast is participation, because this concept is often misapplied. So as nurses, we can unintentionally push families to participate at our comfort level, not theirs. So for example, a father who maybe wants to wait outside while his child is having an IV placed, we can maybe perceive that as an abandonment of that child, but that might actually be the way that he is coping with the situation. There are tasks and interventions that we start to do on a very regular basis that can feel routine to us, that we have to recognize families are not going to be as familiar with, and they're going to have different comfort levels, and we have to assume goodwill, and that they're, assume that their level of participation in that moment is the best that they can do, and not attribute some sort of negative justification to it just because we think that they should be able to do it. So both atraumatic and family-centered care are very essential in reducing the stress of hospitalization and medical treatments for children. The focus is on creating a supportive environment that helps promote healing and then considers the child's and family's emotional well-being. So in pediatrics, your approach is often more important than what you are doing. And you're going to hear me say this a lot, all right? Your approach is often more important than what you are doing. So a big part of your clinical experience this semester is going to be adapting how you provide care to ensure that you can successfully perform the assessments and interventions that you need to do. Some of the biggest wins that students have is managing to get an accurate blood pressure on an 18-month-old child that cries every time that they sense that you're going to come into the room, right? It can be difficult and it can feel discouraging for students to have that extra challenge when you're already nervous, but you have to recognize that there are certain things that are going to be hard, but the consequences of failing at them aren't super grave, right? If you can't get the temperature on your kiddo, I want you to at least try. And if you still can't do it, then you reach out to your clinical instructor or to a peer or to a healthcare tech and have them model it and help you do it. And eventually you will get it done. But going in there and trying and not being able to get it the first time is a learning process, right? And it allows you to go in and adapt your approach differently the next time. And if you view it as more of a positive challenge rather than something to be scared and afraid of, you're going to enjoy that time a lot more, and you're going to turn that fear into curiosity and excitement. So the good news here is that even if you don't want to be a peds nurse, makes me sad, but there's valuable learning that happens in this course. If you are learning to adjust your approach, that's just one part of it. But another benefit that I like to point out or highlight during clinical is the ability to see these disease processes without all the distractions of an 80-year health history that you would have in an adult. So if your PEDS patient has pneumonia, they likely only have pneumonia. And so you can really distill down those significant signs and symptoms of a pneumonia without having to filter out everything else. You can really see the cause and effect and then carry that knowledge into whatever other specialty you end up working in. Also, what I want you to really start learning right out of the gate in PEDS is that all these specialties that you're in are not, we teach them in separate classes, but they're not part of their own silos. The body is the body is the body, right? Our anatomy is the same across the lifespan. Everyone has a heart and lungs and a hematological system and muscles, and they all fail in the same way. And so if you can start building that framework now of understanding that everything is patterns and categories in nursing, and learning what you can see and touch and hear to assess a patient and to help fix whatever it is that might be going wrong, that's what you want to focus on. And there's not a huge difference between cardiac in adults and cardiac in children. The underlying causes might be different, but the effects that it's going to have on the body is going to be the same. And so once you start kind of creating those patterns in your brain and build that framework or that skeleton to start kind of putting all of your new information into, you're going to find that clinical judgment and that learning acquisition is really going to come on a lot faster. And I hope to help you all with that. And that is why I ask why all the time, right? So as we move through the next 4 months, you become more comfortable in being able to do that, and you can carry it into your new grad life and continue to learn in your careers with that information. So real quickly, got a couple more slides before we wrap up here. The role of the PEDS nurse is similar to that of the adult nurse. As I just mentioned, we're still focusing on advocacy and ethics, building therapeutic relationships, support, collaborating with interdisciplinary teams. The big difference that we're going to kind of pay attention to here is health and injury prevention. All right, simply due to the developmental needs. Anticipatory guidance is huge in pediatrics. We're usually educating families on what is coming next for their children, especially in the outpatient setting. Injury prevention really relies a lot on the knowledge of developmental stages. So is your toddler starting to walk? And now we have to start talking about falls. Is this toddler starting to open and close doors? And so maybe last month they didn't have to lock their cabinets yet, but now they have to go through and lock and childproof all of their cabinets. Is your school-age child starting to ride a bike? And now we are discussing road safety and helmets, those sorts of things. Health promotion and health optimization doesn't only include care during illness, right? Like I just demonstrated, but also anticipatory guidance and then preventative care such as vaccines, addressing social determinants of health, screening for neglect, abuse, and human trafficking. There's a lot of talk about nutrition, dental care, sleep, and exercise at well visits. And these all rely on a strong understanding of development to provide accurate information for the family. So real world situations, right? Are you really going to go into inpatient peds and become a developmental specialist? Probably not. All right. But we still need to know it because you're still going to be interacting with these children, and it is a lot easier to kind of know where they are developmentally and be able to adjust our care based on that development than if we go in there and we don't know it all and we try to talk to a 3-year-old as though they're 13. And this works across the lifespan because even adults function at different developmental stages. We don't all reach formal operations and use our critical thinking skills to the max capacity, even if we're 35, 40, or 60. So there are going to be patients in all specialties that we are going to have to assess cognitively and developmentally and treat them according to where they are, not where we expect them to be. And that's sort of the crux of developmental peds, okay? A child's health is profoundly shaped by their environment. Remember, nature versus nurture. So we have to be really competent in assessing and respecting diverse family structures, parenting styles, cultural and religious beliefs that will impact their healthcare decisions. Even their economic factors like their socioeconomic status can influence everything from access to nutrition to housing security to access to care. So these are known, as you may know, as the social determinants of health, or SDOH, and they have a direct and significant impact on kids' well-being. Families are defined by those within the family. So there are almost unlimited definitions of family. It's important that we respect that family unit as it is explained to us by the family members within it. So some examples include single parents, divorced parents, blended parenting, adoptive and foster parenting, for example. There are implications for these structures, such as a single parent being at increased risk for some social, emotional, financial, or physical impacts. Adoption and foster care, or even divorced families, might require more trauma-informed care and consistent routines so that that child feels secure. So the assessment of the family structure is super important. And again, more so for working with that family for a long time and over a long period, where we require that bigger picture to help guide them. But even in the hospital, it can be important. We often are working with families that have DCFS involvement, and understanding, what that dynamic is for safety purposes is really important. Unlike in adults, children are strongly influenced by their parents. So child rearing styles can have an impact. Every well-child visit should include counseling on effective discipline strategies, with an emphasis on teaching and relationship building over punishment. Parenting styles are usually passed down from generation to generation. Believe it or not, there's not a lot of guidebooks on how to be a parent. I mean, there's books, but you have to be willing to read them, and then you have to be able to execute the things that you read. And more often than not, that's really difficult. And a lot of families don't have the resources, whatever it might be, and so they will usually just parent the way that they were parented. So education can sometimes help in situations where caregivers may not have had someone to learn anything different from. And then we have social influences that we need to consider, like screen time and social media, peer groups, and then even the prevalence and effects of adverse childhood experiences, which are becoming more and more relevant in the current research about mental health. So here's some trends and issues that we see in peds nursing you should be aware of. Again, don't have to memorize this, but it's context, all right? These are areas that are receiving a lot of research attention and media attention, so it's important that we know how they impact children. SDOH here relates to the essential resources that impact their well-being and longevity. So you can see the 5 domains here below on the graph. Other issues that we have to take into consideration are social media and its impact on children. That often ties into bullying, both online and in person. Gender identity and human trafficking have gained some momentum in the media, and we have research building in those areas on how to best support children and collaborate with the appropriate resources for assistance there. And then we have medical trends in this age group. Childhood obesity is on the rise, bringing with it an increase in conditions like type 2 diabetes and hypertension that 20, 30 years ago we didn't see as much in this age group. We are also on the front lines of addressing vaccine hesitancy, which has led to a decline in immunization rates for preventable diseases. I just saw data 3 days ago saying that this year's measles cases are the second highest in like 20 years, 2 decades. So that's becoming really important as well. So if you're ever looking for research opportunities in pediatrics, this is a good launching pad to get started. This concludes our first lecture. So the next lecture is going to address the inevitable. You have to interact with a child. What do you do, right? PEDS assessment is next up. I'll see you there.